Got it. You talked about, I didn't get it, but for this, I got it. Hello, and welcome back to DocTalk. I'm Lissa Klein, this is Dr. Janet Choi, and this is our episode of DocTalk on PCOS, or Polycystic Ovarian Syndrome. September is PCOS Awareness.
I had no idea.
Yes, PCOS Awareness Month. And so a lot of people are talking about PCOS. What is it?
Good.
What are the symptoms? And so I figured that you might like if we talked to a doc about it. So that's what we're going to do today.
Great.
Talk to a doc.
Let's talk.
Let's jump right in. I love that there are awareness months for women's health issues. That is great. And so let's start with, what is PCOS?
So Polycystic Ovarian Syndrome is a combination of clinical criteria. And I try to explain to patients it's if you have 2 of 3 of these things. So one is irregular or absent periods. And irregular, we were just talking about this before we went live. What is an irregular period? I'll have some patients come in the door saying, all right, I usually have 28-day periods, but this month it was 32. That's totally irregular, right? And I'm like, not quite. Like a 4-day window is totally fine. Irregular periods, when there's more than a week or 2-week fluctuation in the predictability and schedule of your period. So PCOS patients with polycystic ovarian syndrome, because they're not ovulating very regularly, they'll have irregular periods, like a period once every 3 months or once every 6 months, or sometimes not at all after they go through menarche, which is their very first lifetime period. So that's 1, irregular absent periods. 2 is either blood work, so your doctor, after you talk about your symptoms, and say, listen, I've been noticing that I have a lot of acne on my face or on my back or on my chest, and or facial hair growth that's really bothersome, like upper lip hair, chin hair.
Chin, yeah.
Yep, periareolar, so nipple hair, linea alba hair on your midline of your abdomen. So those are areas where sometimes you can have unwanted hair growth. So signs of hyperandrogenism, either through those kind of symptoms or in blood work, an elevated testosterone level, and or elevated DHEAS level. That's an androgen that's produced by both ovaries and adrenals, but chiefly by the adrenals.
AMH?
AMH?
Not
So it's
really?
interesting. Like the current guidelines don't use AMH alone to diagnose PCOS.
AMH is anti-Mullerian hormone. It's a blood test.
Yeah. Although frequently, especially younger women with PCOS will have relatively high AMH levels.
Interesting.
And then the last one is polycystic looking ovaries on ultrasound. So some people will be like, oh, I have PCOS because I have polycystic looking ovaries. And I'm like, no, not necessarily. If you have regular cycles, but you have lots of little follicles on ultrasound, that doesn't in and of itself give you the diagnosis of PCOS. So 2 of those 3.
Interesting. And there's no definitive cause. We don't know what causes these sort of constellation of symptoms.
There might be some genetic issues, like it might run in families, some allele issues and hormone receptor mutations and things like that, but no, it's not really clear.
And people with PCOS have elevated androgen, so what's considered
Frequently,
male
yes.
hormones.
But it's not really fair to call them male hormones because all healthy females, people who are born with ovaries, will have some low level of circulating testosterone, circulating DHEAS, and
People with
androstenedione.
PCOS just have higher levels of it.
Exactly.
Yeah, got
And
it.
usually higher free-floating levels, so not bound to sex hormone binding globulin, so they kind of create all these sort of unwanted symptoms.
I'm learning so much today. Can you explain what is happening to the body during PCOS? Like you talked about ovaries, it's affecting ovaries. What other sort of parts of a person's body does PCOS affect, or is it mostly just reproductive organs?
No, it's not just reproductive. Let's go through some of the bodily manifestations of polycystic ovarian syndrome besides the acne and the irregular absent periods. Hair is an issue. You have too much in places where you don't want it frequently, so oftentimes people will present with hair on their upper lip, on their chin, around their nipples, on their linea alba, that line between your belly button and your pubic bone, hair growth. But in places where ideally people want hair, sometimes people have hair thinning, so alopecia on their scalp, which is highly distressing. And acanthosis nigricans, so you can actually have hyperpigmentation of skin.
Darkening of skin.
Right, basically around the neck base and also in the groin area. You can get cysts because of the sort of hormonal irregularity, pelvic pain associated with those cysts. Actually, also mood disorder rates also are higher. And
PMDD.
Yep, so like depression, anxiety. not a really great high-quality study, but there was one study suggesting that suicidal ideation rates were also higher among people with PCOS. So it doesn't affect just the reproductive tract.
Interesting.
Yeah.
And it is quite common. Like over
It is.
5 million U.S. women, by women we're talking about karyotypically XX, or people born with ovaries.
Yep.
About 5 million people have it, which is 5 to 10% of premenopausal women, and up to 15% of women and people of reproductive age have PCOS.
Okay.
So it's a lot of
That's a lot.
people who have it, and probably many of those don't even know that they
Right.
do. How is it diagnosed? You talked about this in the beginning, sort of what you have to have one of those three things. Is that how doctors typically diagnose PCOS?
So doctors in the know, and so most people will, if they notice these issues and find that maybe it's something they want to address, will typically turn to their OBGYN. And this is, this is like one of those fairly common issues that OBGYNs are trained to diagnose and help patients with. And so it's not necessarily based on just a blood test.
Right.
Again, it's like two of those three criteria that I listed above. But in addition, they might order some blood work to try to make sure that those irregular periods, for instance, aren't due to a high prolactin level or a dysfunctional thyroid gland, which is super common too. And they might also, check your testosterone level as well. So they're going to do a history taking, a physical exam, potentially a pelvic ultrasound, and blood work.
And we talked about it being super common. Do you think, and that there are probably a good number of people who aren't diagnosed, why do you think that is? Do you think it's lack of understanding
I think
of
it's
the patient?
maybe a lack of understanding or education or awareness on the patient side, which is why we're doing this DocTalk and why it's September. September is PCOS Awareness Month. And maybe some doctors are less comfortable talking about it and diagnosing it, or less familiar. And so it could be a two-sided issue.
Yep, makes total sense. We talked about insulin resistance. How does insulin
How
resistance?
insolent. Your ovaries are
insolent.
insolent.
Yes. How dare they?
Yeah.
How does that trigger a domino effect for PCOS, insulin resistance?
So with insulin resistance, which again kind of crops up in a lot of individuals with PCOS, there are some theories insulin actually may potentiate the luteinizing hormone. So LH is one of those key pituitary hormones that helps drive ovulation if you have a follicle and a mature egg all ready to go and release. But if you don't, and you just have all these little small follicles, that LH kind of stimulates those small follicles and the theca cells to make androgens. Now I'm getting totally nerdy. And insulin may actually further heighten that LH impact.
Got it. You talked about, I didn't get it, but
Got
I'm
it.
just, for this, I got it. We talked about all of the symptoms and like things that may prompt you to talk to your doctor. I think that's
Right.
important to say, like, I notice darkening in my skin, or I have belly fat or unwanted hair, etc., irregular periods. So raising those things to your doctor might be helpful. What other conditions is PCOS associated with?
Well, one that you and I are very well familiar with, given the work that we do with Progyny, is infertility. So in order to be able to try to conceive on your own without any medical assistance, you need to ovulate with some regularity, release an egg. And although some women with PCOS will on occasion ovulate and conceive on their own, it becomes more difficult if you're only ovulating once every 6 months, for an instance, right? So fertility issues.
Yep, fertility. Diabetes you talked about, and gestational diabetes.
Gestational diabetes. Miscarriage rates also potentially
Interesting.
higher with women
Higher.
with PCOS.
Cardiovascular disease.
Yeah, big thing also, especially as one gets older. Metabolic syndrome, heart disease, unhealthy lipid profiles, so more of the LDL versus the healthy HDL, right, on your cholesterol profiling. Potentially also higher risk for uterine cancer, because if you're not having that monthly balance between your estrogen levels going up and then after you ovulate your progesterone levels to protect your endometrial lining, your uterine lining, that puts you at higher risk of uterine hyperplasia and then cancer down the road. So it's, all these things are a big issue.
It's interesting. I think of it very much is just a benign thing and it's mostly irregular periods, but talking to you, realizing that that's not the case, and so diagnosis is important.
Lots of factors, which is why it's really important to make sure that you're getting yourself taken care of.
Yep, and talking to your doctor about something that might not seem normal. And so we talked about the symptoms, which sound horrible. We talked about other health conditions. How would, if someone goes to their doctor, gets diagnosed with PCOS, what might they expect in terms of treatment?
So it depends on where they are in their life, depends on what, how they're feeling about family planning. If they say to their doctor, hi, I'm not ready yet to even try for pregnancy, nothing on the future horizon. I just want to kind of better control all these symptoms, help me regularize my periods, for one instance. For example, is sometimes the doctor might, if appropriate, prescribe a birth control pill or a Mirena or a progesterone IUD, right, to help protect the uterus and also give you that much needed contraception if you're sexually active. They may also, depending on your BMI, if you're in the overweight or obese category, might suggest that you team up with a registered dietitian and work on healthy eating, as well as maybe a modest exercise regimen to help try to lower some of that weight that you have, because that actually might help improve your hormonal balance. Right?
And there's also something that's often recommended or metformin or Femara.
Yes, absolutely. So,
Dr. Klein.
Yes, Dr. Klein, your Professor Klein, was what we call our behind the scenes.
Yes.
So metformin is used to manage type 2 diabetes. It's a great medication to use because it's pretty well tolerated. It doesn't make you bottom out your sugar, so you don't pass out from hypoglycemia. And with metformin usage, people will sometimes lose weight, which all kind of works along with the metformin activity to sometimes improve that hormonal imbalance and actually helps to regularize people's periods.
Yep. There's no cure. I think often people go to their doctor and they're like, yeah, I find birth control, but like I want you to solve this and cure it. There's
to
no
fix
cure.
me. And there's no need to, but there are ways to try to work with your doctor to address those symptoms so that they kind of either minimize, go away, and also put you on the path for success for like a long-term healthy life. Right?
You mentioned...
Oh, actually, you mentioned Femara. Sorry to cut you off, Dr. Klein.
Please.
But if you're trying to conceive, and you say to your doctor, hey, I am not getting periods and I haven't been using protection and I haven't gotten pregnant in months, they might have you go see a reproductive endocrinologist and have them prescribe you an ovulation induction agent like Clomid or Femara to help your body ovulate, because most women, especially if they're younger with PCOS, have lots of eggs in their ovaries. They just need the right wake-up call, and that might get you over the hurdle of not ovulating, so you can try to conceive.
Got it.
Yeah.
That I did really get.
Yes.
I really understood that part. So you mentioned weight gain, and that could be both caused by PCOS and contribute to some of the other symptoms.
Exactly. It's a vicious cycle.
Yep. How might GLP-1s, which are very hot, everyone's talking about GLP-1s, like Ozempic, Wegovy, there are others. How might GLP-1s be used with PCOS treatment?
So there was a European PCOS guidelines committee that came out recently, and ASRM endorsed their recommendations. So for individuals who are struggling with, again, unhealthy range BMIs, overweight, obese, with PCOS, and not trying to actively get pregnant, because GLP-1 use in people who are trying to conceive is not recommended.
Contraindicated.
Yeah, because they may be teratogenic, actually, right? Birth defect causing. But there is some recommendation to, in those kind of cases, and if other measures to control weight haven't worked, to have the doctor prescribe something like Victoza, which is an old school GLP-1, or one of the newer ones, again, under the safe supervision of a physician who knows how to manage that.
Yep. This is not on our script, executive producer, in addition to doctor. I sometimes, because of my fertility is something I look at a lot, and menopause and all of these things, I get served a lot of content on social media, and some of that content is from influencers saying here's a detox, or I'm going to balance your hormones for you, and here's a supplement that you can take to cure your PCOS. What do you think about that?
Talk to your doctor, please.
Yes.
Ideally your OBGYN, and or if they want to help you but just are so busy, because I see how my OBGYN colleagues are allotted maybe 5 minutes per patient, a reproductive endocrinologist to kind of walk you through how to manage your symptoms so you can have a better quality of life too.
Agreed. And sometimes it's helpful before you see that doctor, sort of write down all of your symptoms, write
Yes.
down your questions, because they are limited in time, and being prepped, bring a friend with you. Sometimes it's helpful. They might hear things
A
that
buddy,
you don't.
right?
Yeah.
So they can actually
Buddy.
listen. But I like the idea of writing down your questions and your symptoms. And nothing is too silly to ask about, quite honestly. Your doctors want to be able to help you. So write those things down.
Yep. Love it.
Yeah.
Anything else you want to say about PCOS?
No,
I'm sorry,
but you're
keep
not
doing-
alone, right?
Yeah.
As Professor Klein here just said, it affects close to 5 to 15% of the female population, and there are solutions to help you.
Yep, agreed. And talk to your doctor. Advocate for yourself. If you're
Yep.
not being heard or listened to, I recommend finding another doctor.
Absolutely.
And that's a wrap on PCOS.
Can I actually ask them something? With PCOS, what is the earliest someone can be diagnosed? Kind of like with menopause, you can't actually be menopausal until you've gone a year without
Yep.
your period. So I know that when people first get their period, it can be inconsistent and not mean anything. So at what point would someone be diagnosed?
We have a live audience question.
A live, very intelligent audience
yes.
member question. It's not a trick question. So how early can you get a diagnosis of PCOS? So bear in mind, in menarche, when a female goes through puberty and starts to actually have her hypothalamic pituitary axis wake up and she starts having periods, it can take a year or 2 or even 3 for that full communication and control system from the brain to the ovaries to really kind of solidify and
Even out.
stabilize,
Yeah.
right? And so it might take a few years after you've had your first period before you can actually talk to somebody about getting this diagnosis. But again, it doesn't hurt to talk to your pediatrician or gynecologist if you have questions or concerns. Especially if you say, hey, listen, my older sister, my mom, my aunt, they all had PCOS. I'm pretty convinced that I'm on track. What can I do now?
Yeah. So once
Good question.
very
Yeah,
good
really
question.
good. Gold star.
So if you're a few months or a few years rather post menarche or post first period and your periods are still abnormal, it's
Yeah.
a good time to talk to your doctor.
Exactly.
Yeah, we love
Thanks
it.
so much.
And so PCOS, like we said, can be really hard to understand because of the really different symptoms and overlapping conditions. But the good news is, as Dr. Choi mentioned, with proper medical advice and seeing a physician about it, there are ways to help improve quality of life and help mitigate some of those symptoms.
Absolutely.
Which is important. If you're navigating PCOS, like Dr. Choi said, you're not alone. There are ways to find support. There are a lot of really good communities out there too. So talk to a doctor, find community, talk to people similar to you. And stay tuned for more episodes about PCOS and other topics. And if you have a topic that you are just dying to hear more about, to talk to a doc about,
Send it to us.
yes, send it to us and we will doc talk about it. Thank you so much.
Thank you.